Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we have a lot of people on this podcast with us today.
We've got a big podcast for you folks. We have in the room, we have Stephanie Rogers, who's in the Division of Geriatrics, geriatrician here at UCSF. Welcome to is this your first Jerry Pal podcast?
This is my first one.
First, but not last Jerry Pal podcast. And then we have Matthew Groudon, who's visiting from Boston, who is a chief resident in internal medicine at the Brigham and Women's Hospital and did a geriatrics fellowship last year. Welcome to Jerry Pal Podcast.
Thank you.
And we are not minimizing the amount of people on this podcast.
We also have two people on the Skype line. Yes. So we have Chris Moriates, who's a hospitalist at Del Med and works with Vinny, Arora, who's a professor at the University of Chicago and also a hospitalist and a social media star. And they both work at a nonprofit called Costs of Care. Welcome, Chris. Welcome, Vinny.
Thank you.
Yeah.
So we're going to be talking about Vinny's and Chris's article called Tackling the Minimizers Hiding Behind High-Value Care.
Ooh.
This should be a good controversial subject.
Yeah.
But before we do, hoping for a song request. I think the song request is going to go to Stephanie.
Okay. I am going to request one of my favorite fiddle songs, The Devil Went Down to Georgia.
And awesomely, you're going to play the fiddle part, which is clearly going to be the best part about this song because it's amazing.
We'll see about that.
We had opera on last week, and we're doing fiddles
We're
this
stretching
week.
in new directions, Eric. We're going in new directions.
We haven't done. I want to see you do hip hop or like
that
rap, Alex.
That hasn't happened yet. There was that time somebody requested Alicia Keys, and I played one stanza. All right. Here we go. 1, 2, 3, 4. The devil went down to Georgia. He was looking for a soul to steal. He was in a bind because he was way behind. He was willing to make a deal. When he came across this young man sawing on a fiddle and playing it hot, and the devil jumped up on a hickory stump and said, "Let me tell you what. I guess you didn't know it, but I'm a fiddle player too. And if you'd care to take a dare, I'll make a bet with you. Well, you play a pretty good fiddle, boy, and I'll give the devil his due. I bet a fiddle of gold against your soul, because I think I'm better than you." Boy said, "My name's Johnny, and it might be a sin, but I'll take your bet you're gonna regret, because I'm the best that's ever been. Johnny, roll up your bow and play your fiddle hard, because hell broke loose in Georgia, and the devil plays it hard. And if you get this shiny fiddle made of gold, but if you lose, the devil gets your soul." That was perfect in every way. See, I told you the best part was going to be the fiddle.
That's awesome. I think you sounded great.
Terrific fiddle playing there. That's amazing.
That was pretty awesome. I am looking for. You're going to do the full song at the end. Is that the plan?
No.
Someday, though, we're going to practice and we're going to really. Yeah. We're going to get the band together, I think.
Do you have a name for the band?
Not yet.
The Minimizers.
There you go.
Well, Chris, you can do punk rock. That could be your next piece.
Ooh, I like that.
Chris, do you play in a band?
No, but when I moved to Austin, Texas, was the first time I didn't live in like an apartment or dorm environment since college. So the first thing I did was buy a Marshall amplifier for my guitar and fulfilled all my 16-year-old dreams.
Yes.
So, but I was in punk bands in high school and college. So.
Well, I feel like you live in Austin. You have to be in a band now, right?
Yeah. Totally, I'm working on it.
Yeah, you got to play it South by Southwest. That's when you know you made it.
So, we are going to be talking about your article published in Journal of Hospital Medicine in May of 2019 called Tackling the Minimizers Hiding Behind High-Value Care. Can you give us like a 2-sentence description of what a minimizer is before we kind of go into this article?
Yeah, sure. A minimizer is basically we denote it as a trainee who is using high value care as a backdrop and an excuse to not order a test and to do less when in fact that test is indicated.
Whew. So before we talk more about that, like how did you get interested in this subject? You guys, what organization did you say you're a part of?
Cost of care.
Cost of care. Is that organization devoted to increasing the cost of care?
We do that well in this country.
How else can we increase cost of care? That kind of sounds like the opposite of kind of a lot of what you focused on in the past. So how did you get interested in the idea of minimizers as a subject?
Well, like most things, I think, when you're on service as a hospitalist, you get ideas. And I think Chris and I both view ourselves on the front end of the high value care movement as hospitalists and teachers, and really highlighting the importance of things like choosing wisely and making sure that our trainees are not excessively ordering tests or, dealing with overuse. But one of the things I had noticed was that sometimes I would encounter a resident, usually a burned out resident, somebody who was trying to cut corners, who was like, I think the patient can go home and, we don't need to order a chest x-ray. And I'm like, but they might have pneumonia and that's important to know. And they were like, well, I'm trying to practice high value care. And I'm like, that's not exactly how high value care works. And I had just thought it was happening to me. But then in conversations with Chris, we were both like, this is something, and something is out there, and we need to be on the forefront of calling it out so that this is not sort of misappropriated as something that's part of the high value care movement.
Yeah, I think for those who may not know, Vinny and I spent the last at least 8 years of our careers really trying to push the high value care movement. So the idea that overuse causes harm physically and financially, and we need to cut out waste and not do too much. And I actually remember, I think I was either a first year faculty member, maybe when I was a resident, and I was giving one of my first talks on this at UCSF. And one of the residents raised their hands and said, aren't you worried that the pendulum's going to swing back the other way? And if we start doing this, we're going to do too little. And I totally scoffed. I was like, what, are you kidding? Do you know how far we'd have to go to do that? And I think a couple things had happened. One is I left San Francisco and joined the real world, which was interesting.
Wait.
There's another
Hold on. We don't live in a bubble. Are you kidding me?
You moved to San Francisco to Austin. Let's be fair.
It's like the same place.
It is, yeah.
Just hotter.
It is the San Francisco of Texas.
That's right. Better music.
It is becoming the same place as my wife and I were realizing last night when we couldn't get a reservation at any restaurant. We were like, what happened here the last 3 years?
There you go.
But honestly, when I started to realize that there is a lot of underuse that happens as well. And then as Vinny and I reflected, we said, when you think about it, they're rare, but there have been minimizers all along in residency training, right? The joke is always that, as a intern, you're scared of everything. You want to order everything. And, as you go through your residency training, you start to look for the most benign explanation, or perhaps, the most cynical explanation for any given symptom and sign. And what we worried was, particularly with us, they would see us and they would think that, oh, well, now I've got a socially acceptable banner to put that behavior under, right? Instead of calling it being cynical, instead of calling it like, I'm trying to shrug this off, now I could be like, well, I'm just trying to practice high value care. And Vinny and I are like, that's dangerous. And we've seen it. And maybe it's because that's how they present it to us. So we thought we'd put it out there.
Yeah, and you talk about this a little bit in your article, but I think you were trying to discuss a few reasons of why you think people do that. And I think some of the reasons you stated were burnout and just general, this idea of shifting care to other providers sometimes, like that's an outpatient issue, which I think is reasonable. But I was wondering, like how you kind of, when you see that, what do you do or what do you ask the residents?
Well, I definitely always start with what's best for this patient and really try to ground yourself in As an attending, you're really the role model. You're trying to really balance not only your trainees' needs, but really also reflect what it is that your patient needs and model that for your trainees. And I think that sometimes, residency is hard, training is hard. In the middle of the night, you can get clouded, especially when you're dealing with all this pressures. And I think as an attending, you often have to be there to say, let's stop and really just think, what does this patient really need? And would they be benefited by calling this consult or by, watching them for one more day to make sure that X, Y, or Z was done? And 9 times out of 10, the resident at deep down, they know that that's the right thing. And so they will be like, yeah, sure. And so it was almost like they were trying to float an idea, see if their idea floated past the attending and, moves forward. But when you call it out, I think they start to realize that, okay, this is important. My attending is not fallen asleep at the wheel, and I need to be much more, careful about defending my decisions. And so I think it's actually part of teaching, letting people know that you need to be prepared to not only put your nickel down, but why you're putting your nickel down.
Yeah, I have to admit, when I first read the article, I kind of had this moment in my head where I was like, I'm a geriatrician. I consider myself, I don't know, a minimizer, but like a minimalist, right? And so I started thinking about what that means and how I make decisions and how I train people to make decisions. And that's why I was grateful for your article, because it really made me kind of solidify, like, what does that mean to be a geriatrician, or what I call a minimalist, which is a little bit different than I think what is going on here. But what it got me thinking about is how we teach this idea. And I think sometimes in geriatrics, the patients that we see are very complex. They have a lot of issues going on. And there's so many other factors that we have to weigh in when we're making a decision on whether or not to, say, get an x-ray when we thought the patient was going to go home, and when is it needed. And so I thought to myself about some of the complex things that we think about, most importantly being patients' goals. And you guys talk about this a little bit in your article. And when you talk about value, you talk about good clinical outcomes for good costs. But I think what gets missed a little bit is like the patient's preferences for not only workup, but treatment and just the burden of healthcare that they have. And so considering those things and talking about those things with patients. And so I always think it's interesting to talk to residents and ask this exact question, like, why don't you want to get the x-ray? What can we elicit from the patient to try to understand if this fits with what's going on? For us, we have a lot of patients that just want to go home and don't want to be in the hospital anymore. So we try to help them meet their goals. But so I just thought that was really interesting. And I was also just wondering if you have some specific stories of things that happened from residents, maybe any harms that have happened or anything like that.
Yeah. So Stephanie, if I can, I actually want to first jump in and just make the point that you made, which I sort of wish now we made explicitly in our article, which is minimizer is different than minimalist. And that's really important, right? Because you can be a minimalist, particularly in the correct setting, and being a geriatrician, that is the correct setting. I think, Vinny and I are certainly on board with that approach. Minimizer, in a way, is a pathologic version, in that you are looking for the most benign explanation, and oftentimes the motivation, if you get under it, is your own self-motivation for whatever reason, the areas we pointed out, like to make your work less, to, or even if it's not as malignant as that, and it simply is just, they're not purposely doing it, but it's a harmful response, whereas a minimalist response, maybe you are actually looking out for what's best for the patient. And I think that's what Vinny and I were saying, was what we don't want is for the harmful motivation, the harmful response of a minimizer, to now be able to hide behind the flag that we have hoisted up and said, this is good care. Look for, being a minimalist, and minimizers are now saying, look at me, I'm a minimalist. Does that make sense? So I at least, and I'm interested in Vinny, but make a distinction in mind of, like, what is the underlying source of that behavior.
Absolutely. And I mean, I especially think that, as geriatricians, you see sort of the inpatient and outpatient spectrum across the continuum, and even people at home. And so setting is part of this. And that's why I think this really resonated with our world in hospital medicine, because when you only have that narrow slice, it's very easy to be like, oh, that can be worked up as an outpatient. And so I see minimizing often as a patient will report a complaint, and perhaps because of anchoring, or, you're like, as you mentioned, Stephanie, there's only so many complaints you're dealing with because this is like a patient with a lot of illnesses. You're focused on the top few problems that are acute in the hospital. The patient's now saying, oh, they have back pain, they have back pain, they have back pain. And, maybe your resident's like, oh, they have back pain, it's chronic, and so you can not only be a minimizer by just like trying to overlook doing a test, but you could actually overlook a symptom by saying, okay, well, this doesn't need to be worked up right now. And I have examples where, when you think about what we do as stewards of hospital care, it's really to provide the best value, high quality care, but also be efficient. And there's nothing more concerning than when 4 or 5 days into a hospitalization, that minimized problem, which we didn't look into, like that back pain, becomes the patient's top problem. And on rounds, you're like, let's step back here. Like, this is the patient's not going to go home because we haven't addressed their main problem. And then lo and behold, they end up having like a major issue with their back that needs to be worked up and need a pain injection or something like that. So I give you that as an example of a lot of times there are some really biases at play. Some of them are cognitive biases where you're kind of, anchoring on the top problem. The other biases are some implicit biases, even where you're tending to ignore somebody's problem because you're like, well, this can be settled later. It doesn't need to be my problem right now. And I'm just going to wrap up problem 1, 2, and 3, and then we're going to send them home. And so I think that's where you get into that dangerous zone of minimizing. And that's not to say every problem. I mean, the extreme is I've seen residents who work up every single problem in the hospital, and you're like, okay, this really can be solved. And, this is better left for a primary care physician to discuss. And so there's that middle ground. But with the high value care movement, I think, as Chris mentioned, it's created this sort of defense for people to hide behind. And I've seen it enough times that it was irking me and it was really bothering me that I was like, we really need to call this out, Chris, so that people who are seeing this are not are aware that we have seen it too, and this is not what we mean by high value care.
You asked for a specific example, and without too much, we had a patient here who died, who's presented at M&M from a bowel perf, and they didn't get a CT scan, and the abdominal pain was completely minimized. Oh, this patient uses opioids. Oh, this patient, and a ton of stuff. And once again, the risk is that lack of getting that CT scan can be sort of, as opposed to recognizing that there were biases at play and this was a misdiagnosis and so on and so forth, it can instead be like, well, we didn't want to overuse scanning. We don't want to do this. And so that was the thing, is we want to make sure that people are really putting this in the right balance. And Vinny and I wanted to make sure that we were kind of putting a stop to, or, balancing that scale, because we had pushed so hard, I think, appropriately on the other end of that scale. Yeah.
I guess, as I think about this, one thing that's coming to mind is I'm wondering if minimizers exist, and you're kind of alluding to this, in what way in different contexts, different populations are the subject of the minimization. So are there certain racial groups or socioeconomic strata or whatever, however you slice and dice things, that are the subject of different trainees minimizing in different contexts. And I'm curious if you guys could expand on that as kind of like to your point of using high value care as a shield, that in fact it may just be other inherent biases that we're, using that as a justification not to follow up on the pain of someone who's often using opioids because we don't really want to know where that's going for some inherent bias that we have.
It's a great point. And actually, I will tell you, sometimes when you talk about your article or your idea, like we're doing here, kind of your wheel spin. So I will say I have become a lot more interested in implicit bias, and I've been reading a lot more about this topic. And I do think that what you're saying is very salient, that it's more easy to minimize pain coming from an African American woman, for example. And maybe the issue of the minimizer is that we are concerned that, one, that shouldn't happen, to number one, and two, that hiding behind the high value care movement as your socially acceptable banner or your defense is not appropriate, and furthermore would undermine the high value care movement. There's I remember Chris telling me an interesting Chris, I think you had said something like, we're always one case away from somebody unraveling high value care, because they're going to say, well, I didn't order that and I missed this X, Y, or Z. And so you always have that in your head to be like, of course, that you're standing behind appropriate care, but it's so easy in our environment to be charged and to be like, oh, well, why didn't you order this CT and we missed this diagnosis? And so that's where it's unpacking that the word value does not mean do less every single time. And I think that's the hard part, is when it's like almost like when people learn something, when they don't know a lot about the topic and they learn just a little bit, they learn enough to be dangerous. And so this is why I think this is a particular issue with residents, because people can be really jazzed up about high value care and also doing less, and even the less is more, nomenclature that's been, promulgated. And really the term value is not doing less, it's doing the right thing. And so that's one of the things I think we really want to spread as a take-home message.
Yeah.
And when you think about value, like how do you define it? Are you using the quality over cost, or how do you think about value? And is that a better term that we just stick with than minimizers and maximizers because of the issues with both? Now we have warring fractions of people in the hospital. Oh, you're just a minimizer. You're just a maximizer.
Yeah, no, I don't think we're advocating for labeling people necessarily like that in the hospital. Value is what we're getting at. We define it generally outcomes that matter to patients over total cost of care. And with cost of care, the way we've conceptualized it in a way is it is ensuring that we're providing care that is safe, that is affordable, and that provides a good experience. That is what people really want. And so the idea is that's the goal that we're leading towards. And I think, as we've talked about, what one of the risks is if you don't apply this in a thoughtful way, you can, as has been pointed out, you can actually worsen disparities if we're not thinking about that and thinking about our biases, as was discussed. So I think that's important to us. But no, absolutely putting it behind value. And I wanted to mention, so Vinny mentioned that comment I made about we're one case away. That actually was a conversation I had with Gurpreet Dhaliwal there at San Francisco VA when I was a first year attending. And I said, I feel as though if we get a CT and it caused harm or something and people presented it, everybody would go like, oh, well, yeah, that just happens. Yeah. But the moment I don't get a CT and it causes harm, everybody's going to say, oh, it's because that guy is all about, choosing wisely and high value care. Mm-hmm. And all of a sudden, everybody's going to backlash against it. And so I was always very worried about that. And now 7 years later or something, I feel like I'm starting to say, well, wait a second, we have enough momentum behind this. One case I don't think is going to unravel this movement anymore. And now I'm a little worried that we're starting to see the opposite effect.
It's interesting. You got the pendulum swinging. But it says an important question here. What is the bigger problem? On a population basis, particularly we're talking about trainees, what do you see on a daily basis? Is the bigger problem people who are ordering unnecessary tests, treatments, consultant requests, or is the bigger problem like low value? Let's rather than unnecessary. Let's say low value test, treatment, and consultant requests, or is the bigger problem minimizers and people who are not ordering tests, treatments, consultant requests that they should be in order to provide the best care for their patients?
We state very clearly in our paper, 100%, it's overuse is the bigger problem. But
absolutely,
yeah.
But I will say that all care is, it's not random. There is a practice pattern based on the people you are working with. And so if you end up on service with a minimizer, somebody who has minimizing tendencies, you're going to go into overdrive being like checking everything to be like, did we get everything we need? And so that's a challenge as a teaching attending, right? I mean, these are actually, we referenced in our paper Jerome Grootman's work on, patients as maximizers and minimizers of their symptoms. And so although we don't want to label people, I do think that there are certain people that have tendencies towards minimizing. And that's where, as an attending, you need to step in and give feedback and teach so that people understand that, okay, they may need to step back and say, all right, what's the best thing for the patient here? And no, this is not high value care. And so I will say, at least from the reason I felt very compelled to write the piece is that in my inpatient block, when you said, what's the problem? Yeah, most of my inpatient blocks, I'm talking about high value care and waste. But the one time I'm not, and I'm not doing it for 14 days straight because I'm paranoid about minimizing, I'm like, okay, this is a very different feeling. And this is something wondered if other attendings had noticed. And clearly they had. I mean, not only Chris, like when the paper got published and we tweeted about it, I mean, there were tons of people who were like, I've seen this happen. And that was really interesting to me to be like, okay, it's important that we have this discussion so that we as physicians, as teachers, are on the lookout for these practice patterns so that we can correct them.
Yeah, and I think you guys are onto something, because I think, we want to avoid these labels for trainees, maximizer or minimizer, because one of the things that I learned in my amazing geriatrics fellowship was this gray area that everything sits in. And I think that's the true art of medicine, right? Like, how do you sit in this gray area with every individual patient? And I think that's what we really need to take time to teach our trainees. I definitely, I'm a geriatrician that works in the hospital, and I would say by far, I feel like I'm running around preventing harm all day long, like trying to get teams to think about why we're ordering something, or trying to get teams to do simple things like remove the telemetry wires. And they're like, well, why? Just in case something happens. And I said, well, this person's all tangled up and they're confused and they're going to fall. And it's surprising to me how hard I have to work to sometimes help them think through some of these decisions that can actually have profound harm on patients.
And that's why I think we should be cautious. And I'm hearing that you guys are cautious with this language, because what I'm also hearing is the idea of minimizers and maximizers focuses on things like tests and medications. But when you're a maximizer, let's say everybody gets a urine culture, every test possible, you're actually minimizing other things that are equally important. There's only so much time in your day, only so much things that you can do. And you're running around, you're minimizing some things, but you're also trying to maximize other things. Mm-hmm. So it's not purely a single construct that we're working with here. It's like trying to get people out of bed. You're maximizing that. It sounds like some other teams are minimizing it, but they're maximizing other things while minimizing kind of this concept of ambulation in the hospital. Thoughts on that, Chris and Vinny?
Yeah, I totally agree. I mean, I think, there's only so much time in the day. And that's why I bring up the symptom of pain, because I think there's obviously tests and treatments, but I think minimizing symptomatology is a very different experience. And we've all had we don't need a label. We've all had a moment in our lifetime as a physician where we have potentially minimized somebody's pain and thought, later on, that was real pain. And so I think that the use of the term minimizer is not as important as minimizing behaviors in the context of whatever you're doing. And so I think what I would say is we want to be on the lookout for minimizing behaviors when it's not appropriate to minimize them. And that's really and that people are hiding behind using the high value movement as the defense for it, which is not appropriate at all.
I just see it, like on my end, like I see so many, I'm going to use the label maximizers so much. And like in my head, I'm seeing so much harm happening.
Right.
And so it's interesting to me that, and I see what you're saying. Like, it's just going to take one bad case where someone doesn't order a CT scan and everybody's up in arms. But what I wish from my world is that everybody was up in arms about the overuse of urine cultures and telemetry and all of these other things. And that's what I get fired up about, So, I think it's just interesting the things that we're seeing that look very different, or maybe they're the same.
Here's the thing. We are 100% fired up about that too. And I guess we take for granted the fact that people already sort of know that about us, and maybe they don't, but like that's literally what we have pushed Choosing Wisely education. We've created curricula around the physical and financial harms of overuse. I am 100% aligned with you about running around the hospital and taking off telemetry wires.
We've published on that.
Yeah.
Right. We've led projects around that. We actually, at UCSF, Think Twice, Stick Once was a project that I helped lead with Dan Wheeler and a whole bunch of residents there years ago about not sticking patients too often. So we're 100% aligned, and it feels like perhaps language is getting in the way of what, because I think what we're trying to say is the same, and yet we've got sort of this concern around how things can be. In fact, we share a concern about how things can be labeled.
Well, Chris,
right?
I think our biggest worry is you leave San Francisco, you go to Texas, and everything's bigger in Texas. We were just worried that you were changing on us.
Now, my residents here will attest. I promise. When I see the 9-year-old too, I say, get that person out of the hospital, right? Like, let's get them home. And we are absolutely aligned with that. But I will also mention, because we're on Jerry Pal, Vinny and I do see a different set of patients in general. We share a lot of patients for sure with y'all, but we see a different set of patients. We're not just talking about patients, geriatric patients or, palliative care patients, where the goals of care may be very different in some settings than what we're saying. Which is not to minimize the overuse issue in all comers, but I just want to point out, we are talking about a different population.
Yeah, but I would argue that we should think about all people in the same way, and I think there's this kind of way we think in geriatrics. But I also am a hospitalist and do hospital medicine, see younger patients, but I think the same way. And I think what's interesting here is about this article that's bringing this up is that I think what we really need to think through is how do we teach this thinking? So not that, should I order it or not, but what are the circumstances where I would order this test and what are the circumstances that I wouldn't? And sometimes that's evidence. Sometimes you're in an evidence-free zone. Sometimes patients' goals are in there, symptom burden, health system burden. All kinds of things weigh into those decisions. And I think we need to kind of encourage residents to start talking through being maybe more explicit about what are the reasons to order this test and what are the reasons to not order this test, and what is the best outcome, what is a likely harm, how likely is that harm, et cetera, and starting to talk through these issues rather than, we think they have pneumonia, maybe order the chest x-ray, and being a little bit nuanced about what's going on in our head, because I think that's the only way they're going to learn this gray area where we exist.
And the thing I just keep thinking about is, and I think we would all agree about this, is just the notion that in the decision not to do things, we have to be just as rigorous, if not more rigorous, in our decision making and the nuanced thinking. That I think that these ideas like less is more, or choosing wisely start from an evidence base that is very rigorous, but sometimes in the article, the example you're giving, they're being used in a more flippant way, but the rigor has to apply, both when you're ordering the test, but just as equally, I think in geriatrics, when we decide not to do things, we're thinking about what are the downstream consequences, what is going to happen with the result here. And that is a very rigorous process as well.
Yeah, I would say the decision to do nothing is probably one of the most complex decisions that you could make. So instead of it being, and what you're seeing is students who are kind of being intellectually lazy and not trying to make that decision. But when you see that, doing nothing actually involves a lot of complex decision making. And it's one of my favorites. The reason I love geriatrics is because nothing is black or right? And you get to kind of tease out all of these little details to decide and work with the patient and family to try to decide what is best here.
And I think this is the hard part, is that what I'm also hearing from you, Steffi, you're doing nothing is actually doing a lot of things. So you're maximizing a lot of things.
Yeah.
Including like not getting a UA or culture, you're working up other things and not falling down potentially a red herring path where a culture is going to come back positive and we're going to feel like we need to treat it. Where at some other points, you are going to be checking those things. So I think that's the challenge, whether or not we're using words like minimizers or maximizers or do nothing, is that they don't actually adequately convey the challenge of both the diagnostic decision making and the therapeutic decision making.
And I think that's why it's important to really think about spotting, minimizing behavior. And I think, as Chris mentioned, by and large, the problems that you're describing are still issues that we all face in hospital medicine, which is tackling overuse and inappropriate use and waste. However, I know some of you have been to a Society of Hospital Medicine meeting, and there's poster after poster and initiative after initiative talking about improving waste and reducing inappropriate stop and choosing wisely. And it's in that context that at least I think what we are describing is this new phenomenon of people hiding behind the movement as a way to justify their minimizing behavior at that moment.
And that's why I love your article too. It really, I love articles that kind of challenge past notions and make us think. And I think your article does a great job of just making us think.
Yeah, absolutely.
I've seen this as well in palliative care. It's a little weird when you're the palliative care consultant and you're like, no, you really should get that CT scan.
Yeah, I do that in geriatrics too.
No, yeah, they have pain. Yeah, they have pancreatic cancer, but there's something else going on here.
Yeah. But I mean, that's the nuance of what we do, right? Over treatment versus under treatment. I'm thinking about that on every single patient, and you're always walking that line. And yeah, you see the same thing where they're like, oh yeah, I was going to discharge this patient. I'm like, hang on a second.
Right.
You're like, they're really sick right now.
Yeah.
Yeah.
Well,
I think, Stephanie, you got at it when you said, well, we're trying, this is the clearest way to say it, I think. You don't want the lazy thinking.
Right.
It doesn't mean doing more, doing less, the point was minimizing our point is it's lazy thinking.
Right.
Yeah.
It's not focused on doing what's right for the patient. It's not focused, and it's lazy thinking, perhaps because of lots of things, because you're overwhelmed, because you're burned out, because there's systemic reasons why that may or may not happen. But that's the area where the attending needs to say, wait a second, this is not in the best interest of the patient. This is not, it's lazy thinking, and you're just using a socially acceptable way to feel good about that.
That's right.
To say, well, I am,
Yeah.
I mean, I definitely think that, the lazy thinking, it's very interesting. You need time to think, and you need the capacity to think, and you need the mental space to think. And we didn't talk a lot about this whole concept of burnout and well-being, but I also think that is another meta trend playing in, which is I particularly seen this when residents are burned out maybe huge number of stretches of inpatient. And why does this set up? Well, if you think about it, doing less is easier. And so all of a sudden you can look like you're practicing high value care. You have this great justification. You're doing less. It's less work for you, but it's not right for the patient. And I think that's been also an aha moment for me, which is that, it's not about whether somebody's a minimizer. It's like, okay, if you see minimizing behavior, ask more questions. Why did they want to push that patient out of the hospital, or why didn't they want to order a renal consult for somebody who's had a doubling of their creatinine for no unexplained reason? And so I think those are the questions, which is, where has your intellectual curiosity and your passion for helping people gone such that you're saying, oh, we don't need to work this up, when in fact you do.
Yeah, and I love the idea, like the doing less, and I can see it both from the minimalizer and the maximizer, who just will order all the consults so they don't have to kind of work it up and think about the case, or order every test so they don't have to think about it. And the idea of kind of the intellectual laziness, or laziness probably not, like we all use shortcuts all the time, using them appropriately, and the concept of wellness and resiliency too around this. Maybe that's the potential issue on either end of this spectrum. Mm-hmm. Well, with that, I really want to thank you for joining us on this podcast.
Thank you, Vinny. Thank you, Chris.
Yeah, thank you.
I always learn so much from you guys.
Yeah.
Love listening.
A lot too.
Yeah, if nothing else came out of publishing this, getting to hang out with you guys and rock out has been fun.
Well, how about we rock out a little bit more? How about we get a little bit more Devil Goes Down to Georgia? Did I do that right?
Devil went down to Georgia.
Can we change it to Devil Went Down to Austin?
The devil went down to Austin.
When the devil finished, Johnny said, "Well, you're pretty good, old son, but sit down in that chair right there and let me show you how it's done. Fire in the mountain, boys, run. The devil in the house of the rising sun. Chicken in the bread pan, hitting out dough. Granny, does your dog bite? No, dog, no."
On a good note.
Yeah, we ended on a good note. Oh boy. Well, I got like half the lyrics. My favorite
South by
line
Southwest,
in there,
here we come.
Yeah.
Chicken in the bread pan, picking out dough. Granny, does your dog bite? No, child, no.
No, child, no.
Where did that come from? I love it. I love it.
Well, Vinny and Chris and Stephanie, thank you for joining us today. Really appreciate all of our listeners for joining us as well. Again, if you haven't had a time to actually share this podcast with your friends, colleagues, or review us on your favorite podcasting app, please take a minute to do so. We always rely on the generosity of our listeners to spread the good news of Jerry Powell.
Thanks, folks. Next time. Bye.
Bye.
Bye.